Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gollin.
Hey everyone! Today we have a special episode brought to you by Artilix. We're going to talk about IBS-C treatment options, and our guest today is Dr. Baha Moshiree. Dr. Moshiree is a leading gastroenterologist and motility expert at Atrium Health Gastroenterology and Hepatology in Charlotte, North Carolina, and she's also professor of medicine at Wake Forest University. Now, if you haven't listened to it, you should check out Dr. Moshiree's episode that we did last year on gastroparesis. It's an amazing episode, and we'll surely you enjoy it. Welcome, Dr. Moshiree, to the show today. We're glad to have you.
Thank you. I'm excited to be here.
We did an initial episode with Dr. Lacey and Dr. Brenner last week, which laid the groundwork about IBS-C. Today, we're going to talk about treatment options for IBS-C. But for those who may not have listened to it, Dr. Moshiree, can you tell us a little bit about what IBS-C is?
So irritable bowel syndrome is a constellation of symptoms that has been designated by a body of experts that are called the Rome experts. This group meets every 10 years in Rome, and we come up with all of the evidence-based data that it really explains best what is this syndrome. It is recurrent abdominal pain that's experienced in patients at least 1 day a week for the past 3 months. Onset of symptoms have to be for at least 6 months. And this is associated with a change in frequency of stools, change in form of stools, and then also it related to defecation. So what that means is that the definition of constipation can be different for different patients. But if it causes significant abdominal pain at the same time, then we call it irritable bowel syndrome with constipation. As an example, sometimes patients don't realize that when they don't have a complete bowel movement, we think of that as constipation. So it's not only that the stools are hard or that they're infrequent, but it's also that they feel that they have to go to the bathroom again after they've already been to the bathroom and they've already defecated.
And also, so for someone, you raised a good point that it could mean different things for different people. So if someone's used to having 2 to 3 bowel movements a day, and then they're going down to less than 1, that would be defined as constipation for that patient.
Yeah, I think so. I mean, if it's hard stools, right? Yeah. And then they say the pain is related to defecation, it doesn't necessarily get better with defecation. But if they experience the pain and it's related around the time of their defecation, that itself is enough, because you only have to have 2 out of the 3 criteria. So wow. Yes.
So how prevalent is IBS-C?
So IBS-C is pretty prevalent. So about 15% of the population, in the United States, the rates have been from 17 to about 15%, but it's not uncommon. It's a subtype of IBS because IBS has 3 different subtypes. So it could be mixed type, where patients alternate between constipation and diarrhea. Then it can be the diarrhea type, where patients have more frequent bowel movements and they also have abdominal pain. And then for the constipated patients, that's about a third of the patients that have constipation predominant IBS. Those patients have the infrequent bowel movements and hard stools that they report.
Yeah, so many people are suffering with this. That's crazy, but it's really an important topic, and I'm glad we're here today. So how is it diagnosed? Would a patient have to undergo some tests, or is it just by observing what their bowel habits are and their pain and telling their doctor? How is it diagnosed?
So with a high degree of assurance, I think a physician, provider, nurse practitioner, APP can make a diagnosis and give the patient assurances as long as there is no alarm symptoms. So it's just a symptom-based criteria. And I know many patients may feel uncomfortable with that, but really we can diagnose most patients based on this patient criteria if the questions and the history that's taken by the practitioner is complete. So that means that alarm symptoms have to be asked. For example, if the patient knows their family, right? Is there a family history of colon cancer? Is there a family history of inflammatory bowel diseases like Crohn's disease and ulcerative colitis? Is there a family history of celiac disease? Does the patient have any bleeding? Obviously, if the patient has rectal bleeding that they report or seen blood in their stools ever, that's an alarm symptom. If the patient has other symptoms such as nausea, vomiting, if they're losing weight, right? If they're losing more than, usually we say about 10 pounds, we start worrying that maybe there's something else that's going on and we need to do other investigations. So I think, iron deficiency anemia outside of your periods being the cause, those things are all alarm symptoms and they do require diagnostic testing. Importantly, in patients, we do colonoscopies if the patient is 45 now and upwards. That's on the screening guidelines that has been recommended by all of our GI societies and by the Cancer Society. And that's just for colon cancer screening. So, that itself is, different than the diagnosis of irritable bowel syndrome. And I think sometimes we get requests from patients to have imaging or colonoscopy and things like that. And it may not necessarily be required unless they have these alarm symptoms.
No, that's a really important point because constipation can exist with these other more serious conditions. So you definitely want to be completely open, as hard as it may be, with your doctor about everything you're experiencing so you can get the right diagnosis. And then that leads us to our next question that everyone's wondering about. How can I get symptom relief? What are my options for this? Once I'm properly diagnosed with IBS-C, what is the doctor going to give me?
Exactly. So I think, the first step, make a diagnosis, assure the patient, as long as they don't have the alarm symptoms, that you are confident about the diagnosis that you're making, and make sure the patient really understands why you're making that decision. And then going into the treatments, right? Because there has to be buy-in from the patient. They're the ones who are going to have to take these drugs chronically. And so they're going to have to be willing to accept that diagnosis. So then the treatment options are actually vast. So, 20 years ago, when we first started out, there was very few drugs that we could use. Now we have drugs that target, the symptoms very nicely. So if the predominant symptom is abdominal pain, we have to make sure that we address the abdominal pain symptoms, and things that can be done, such as, for example, as simple as peppermint oil. So there are substances that are peppermint oil, they're in tablet form, preferred if they're enteric coated. There's some triple coated formulas that can really help and prevent the acid reflux symptoms that you can get from just having peppermint. Oil. But these really help with the abdominal spasms. There's other antispasmodics. The ones in Europe have been more recommended, the ones that are available there. They really help abdominal pain. The ones we have in the United States, as far as the antispasmodics, were not recommended by the American College of Gastroenterology because the data wasn't so robust. But the American Gastroenterologist Association did recommend them for treatment of abdominal pain. And then there's the other gamut of drugs. So there's fiber, right? So soluble fiber can be really helpful. There's many different forms of these, the, Metamucil, Consol, Benefiber, all these are great FiberCon fiber options, some of them brand name, generics are out there, sugar-free options are out there. And as long as there's soluble fiber, having patients supplement those at least 30 grams a day is what we should be intaking as far as fiber intake. That can also help constipation. Things as easy as exercise, right? So there's many studies with yoga and constipation and IBS. It can be very helpful if patients don't exercise. And especially with COVID, many of us are in these, virtual appointments or jobs, sitting in chairs all the time, not really ambulatory as much as we used to be. So I think that has probably created a lot of constipation in many patients. And then making sure that patients drink enough water, right? So I think we all drink enough caffeine. I think that's not really hydration.
Yeah.
A lot of times. And I think, adding something as simple as that. And then drug therapies.
So if a patient came to you, if I came to you and we decided that I was suffering from constipation, the first line, would it be dietary? Would it be trying more fiber? What would you have me do before we went into a prescription product?
Exactly. So, there's a spectrum from constipation to IBS. So chronic idiopathic constipation patients don't necessarily have abdominal pain as their predominant symptom.
Oh, interesting.
So if it's just constipation, exactly. I start with diet, herbal remedies like the peppermint we talked about, kiwi fruit, right? There's been randomized controlled trials.
I saw those last year, right? The studies.
Yeah, they were they were exciting, and they won awards at ACG and from the New Zealand group and also from the University of Michigan group. Sure. And this was so something as easy as kiwi, right? So eating 2 or 3 kiwis, they have 3 grams of fiber each, can be very helpful. But there's other fruits like persimmons, these fruits just have fiber, right? So it's okay to do the fruit from, fruits as a natural resource for your fiber intake. But I think many of us don't eat enough fiber in a certain day. And our, mission is to just increase that, hopefully. But if people can't, then the fiber supplements are helpful, and they're probably faster to ingest maybe than cutting up fruit. But probably the natural way is the best. And then other dietary, changes would be not insoluble fiber. So there are things that are insoluble fiber and roughage, things like celery, for example, is fibrous, but that probably is not going to help really with constipation as much as something that's a soluble fiber.
Now, talk to me about the drugs that I know there's some new ones that are coming down the pipeline that deal with your expert area, the motility. So it could be a motility issue that has nothing to do with our diet, correct?
Yeah, absolutely. So sometimes it could be that some of the patients have spasms in their colon, and that can cause the pain syndrome. So irritable bowel syndrome has many different pathophysiologies, right? So motility is one of them. So motility means that there's a slowness in the movement through the colon, right? And so there are agents that actually help that. These agents we actually call prokinetics, means it's kind of like it helps promote the movement throughout the colon. And these agents act on serotonin in the gut. We actually have 14 receptors for serotonin, which is a neurotransmitter in the GI tract. And so that's a high number of serotonin receptors. And so some of these drugs that activate the serotonin receptors, they're called 5-HT4 agonists. These are things like prucalopride, Montegrity is the brand name, and then tegaserod, which is Zelnorm. These act on serotonin in the gut. Now, prucalopride is only approved for chronic idiopathic constipation, not irritable bowel syndrome. It is given at the 1 milligram and the 2 milligram dose. And what it does is it helps promote motility through the gut. For a patient with IBS that has slow motility, that can be a helpful drug. And then there's Zelnorm, which is the tegaserod, that also acts on serotonin in the gut and promotes the movements throughout the gut. So these are one neurotransmitter that we're targeting.
I find it so fascinating about the mind-gut connection and how there's so many ways to target your gut through the levels of serotonin. That's so interesting to me.
Yeah, no, exactly. And people don't realize that. So we actually treat pain with what's called neuromodulators, right? So neuromodulators really act on this disordered brain-gut interaction. And we see that because we see that in patients, for example, if we distend people's rectum with a balloon that we used to do. These are these rectal distension studies that I know sound like torture. And we used to MRI their brain, but like obtain like functional MRIs that highlights different areas of the brain and what areas are involved in IBS. And what we found was that when you compare an IBS patient to a normal control, in an IBS patient, there's different areas and more parts of the brain that actually highlight in response to pain and in response to just normal distension that may not be painful in a healthy person, but is really painful to an IBS patient. And I think with these mechanisms, we realize there is an abnormal perception of pain. There may be a hypervigilance, meaning that patients experience pain in very different ways, right? They are heightened response for pain. And so this is something we actually mitigate with the neuromodulators. There's also now excitingly virtual reality, right? So virtual reality where, Brandon Spiegel has been really active on this. I know you probably see him on Twitter also, but he's got books and for many chronic diseases, but also just for the experience of abdominal pain, these patients get put in these different rooms and they visualize themselves in a very happy environment. And that actually helps with the experience of pain. For war veterans and PTSD, it's been phenomenal in helping them cancer pain, right? So and same for IBS.
I think it's phenomenal. I was talking to Dr. Spiegel at ACG, and he's got some really cool stuff coming out about the role of gravity in IBS. Have you heard about that? Wait till you hear this stuff.
Yeah, I think that's due to be published probably in a month. But so there's definitely I think progress that's being made. And then what I didn't talk about, so neuromodulators help pain, right? So they really target the pain aspect.
Yeah.
And then there's other agents. So these other agents are called secretagogues. These are agents that we call linaclotide and plecanatide. Now, they work on the guanylate cyclase agonist. They're called guanylate cyclase C agonists. I kind of call them they're like a garden hose in a way, that they work on secretion. So what they
Okay.
come up with is there is secretion of water into the lumen of the intestine, and with that, the patients then have good normal bowel movements. Hopefully, all these agents, of course, have the side effect of diarrhea. That would be, if severe, obviously it's an important measure to make sure patients don't experience diarrhea. But for the most part, patients will have good bowel movements. There's many randomized controlled trials with thousands of patients enrolled for both linaclotide and plecanatide. They help bloating, abdominal pain, and also the symptom of constipation. And of course, bloating is a huge issue in many of these patients, because they experience bloating. You may make everything better, but they're still bloated, right? So that's a hard symptom a lot of times for us to treat. But there's now trials. A lot of the secondary outcomes of many of these trials have proven that these agents also help abdominal pain. Same with plecanatide.
And those the newer drugs that are out there?
So those are newer. I think then there's the newest is probably tenapanor. So tenapanor acts a little bit different than working on CFTR. It's not a guanylate cyclase C agonist. We kind of call this a retainagogue in a way. This was actually coined by Darren Brenner from Western. So what this helps with is with retention of water in the lumen of the intestine. And then with that, patients have improvement of their abdominal pain. And that works through a different mechanism. It works on the sodium pump. It's an inhibitor of the sodium proton pump. So, exchanger. So these are all agents that are really helpful in helping us mitigate the symptom of constipation. But then there's secondary effects for all these agents is that they also help pain, right? Because of course we said that the main definition is for IBS is a recurrent abdominal pain, right?
Right.
So we can treat the constipation, but that doesn't necessarily guarantee that the pain is going to go away, because that's a visceral sensation that they've experienced so chronically that it almost has become like what I call a phantom limb pain. Like
I was going to just ask that because it's so ingrained, and I have IBS myself. So I know sometimes, am I really feeling that, or am I just so used to feeling that I think I'm feeling that?
No, exactly. Right. It's almost like a tick, when you get like a viral infection, like I had COVID and I coughed for like 3 months after that. Right. It's almost like you just get used to coughing.
Habitual. Yeah.
Do it. So that's the visceral sensation. And the only thing that'll cut it off is some kind of neuromodulator. And then these agents actually work on the pain receptors in the wall of the intestinal wall, where the pain receptors are irritated, right? So they kind of cool them down, and then hopefully will keep them calm for a while, enough time so that you forget you had that pain, right? It's almost like that's what we're trying to achieve. And that takes months. So that's not something we can start a patient on and then they're going to feel better tomorrow. Right. So that's what we have to explain to patients. It's not.
Yes. And patients need to be aware of that. And this is the $1 million question. The good news for patients is that there's multiple treatment options out there, from dietary to gut-directed mechanisms, hypnotherapy, digital apps that have evidence behind them, to over-the-counter products, to all of the amazing new pharmaceuticals out there that you described. Now, the $1 million question is, how the heck does the patient know? Obviously, the doctor is guiding them.
Yeah.
But how do you know what the right course of treatment is for you? And, I'm going to refer to that study you probably saw about the disease burden and care seeking of patients with IBS-C. And alarmingly, it's super high, but even more alarming that only 12% of the patients felt that they were satisfied with their symptom control and treatment plan. So there's a whole lot of patients suffering that still feel like they don't have the right treatment plan.
No, absolutely. I think it's stigmatized, right? I think having the diagnosis in a way, right? Many patients will come and tell us, right? So I have the luxury where in my clinic, I get to spend, my residents see that, right? I get to spend a lot of time with patients. I get to ask them about their psychosocial factors. And I know you have an upcoming podcast with Dr. Joe Smith, who's the god of all of this, but basically he'll describe to you what he discovers when he spends time with his patients, right? Because he has the luxury of having 2 or 3 hours. And I think many of these patients go to these clinic where, they discuss it with their primary, but their primary care has 15 minutes. Then they get referred to GI, they get scoped for some reason. And it's probably not appropriate for them to have been scoped, but then the scope is negative. And then they come to us and they're like, well, what do I have then? Like, what do they call me? Now they're calling me IBS, and what should I do now? So it's almost like they've been through two negative experiences in a way, because nobody's treated them. Nobody said, hey, I think this is what you have. You didn't have these alarm symptoms, and I don't need to scope you, or I do need to scope you for cancer screening, but not for this purpose. And then we're going to treat you with this at the same appointment. So I think a lot of that burden is when they do these surveys, right? These are just everybody and their experience and the symptoms. And so there aren't, necessarily getting the right treatment quick enough, right? Because it may take 8 appointments. Sometimes they come to us. I think there was a study that looked at IBS patients, and it said it took like 5 to 8 years for them to get a diagnosis, because they're told so many things. It's like people are scared to say, this is irritable bowel syndrome. This is what you have. But I think patients are open to it. As long as you explain it to them, I do think patients are more accepting of the diagnosis, and then that guides your treatment. So I guess if you spend enough time with the patient and you know their psychosocial risk factors and what may have precipitated all this, some patients, it's just a virus. They went on a trip and they got some kind of infection, right? They came back from Cancun, they had Campylobacter or some bacterial or viral infection, and then now they have post-infectious IBS. Well, that's probably a patient that will probably get better in a year's time. And so you just need to really treat the patient for that time period, and hopefully the symptoms will just go away. But then there's patients that have been sexually abused. They have psychological issues, maybe comorbidities, anxiety, depression, something happened, family death, right? I mean, during COVID, so many people lost family members. I'm sure that created a lot of symptoms, like dyspeptic symptoms and IBS symptoms. So it depends on what has happened to them and then what the patient's open to. I'm a big fan of psychotherapy, right? So I think, we have the luxury of having a GI psychologist at Atrium Health, but not every place does. But now there's prescription-based therapies that are out there that are FDA approved, and you can do hypnotherapy, cognitive behavioral therapy, gut-directed therapies like you were alluding to. And some patients would love that more than going on a neuromodulator. And I think that's their decision, and it's perfectly fine. They don't have to fail anything. It's not a failure on the patient to go to these therapies. You can go to these therapies tomorrow. From my perspective.
So you've given us some wonderful information. And before we wrap it up, I just want to, have some positive hope for our patients that are listening now, and to know that there's a lot of options out there, but it's really about shared decision-making and the patient being collaborative with the provider. What are your tips for patients on how best to begin their treatment plan with their doctor?
Yeah. So I think first, tell your physician why a certain therapy did not work for you, right? So let them know, maybe write it down, because if you forget, right? First of all, write down all the therapies you've had from all the different doctors you've seen. Because what happens sometimes is they come and then they don't know the names of the drugs, or
that's a good idea.
Gave it to them, or how they took it, or how often, or how long they took it, right? So we need to know the duration of therapy. Did they take it? What was the side effect? Sometimes like it's headache, right? Like they'll take a serotonin agonist and they're like, I had headache. So we need to know the side effects. And they didn't fail the medicine. That's the medicine failed them if it doesn't work, right? But we need to know, did they take it correctly? Some of the medicine is taken with food. For example, lubiprostone, we didn't talk about. That's another secretagogue we call. And that drug needs to be taken. That works on the apical sodium channels. That drug needs to be taken with food. Otherwise, you get nauseous. So we have to make sure they took it right way, right? And then there's drugs that need to be taken before you eat. And then there's some that doesn't matter, right? So I think, how did they take it? What else were they doing at the time? We need to know that, right? And then not everyone is open to hearing the psychosocial issues, right? And not every patient can share it the first appointment. That's perfectly fine. But whenever the patient feels they can share it, I think that's best that they do tell us that something else may be going on. And then if they didn't respond to these things, we do what's called anal rectal manometry to find out, maybe it's a pelvic floor outlet obstruction. Maybe there's something else in the pelvic floor, especially in a woman that's had children or people who've had constipation for a while. Maybe it's not even something that a laxative can fix, or a dietary therapy. So I think my advice to patients would be open to your physicians. Once you figure out a physician isn't going to figure out what you have, switch, right? It's perfectly okay to get another opinion with someone you're comfortable with, because IBS is something you're going to have to live with for the rest of your life. You want a physician that you can see chronically, who's open to the change in symptoms. Understand which therapy takes how long, because
that's a great point.
Yeah. Some may be like in 24 hours, you'll have a bowel movement, but the pain is not going to go away for weeks. So yeah, so I think learn that, ask those questions, write down those questions and ask your, caretaker, whoever they may be. Also understand that we all have this electronic system and the messages are a burden. So I think there's some things that are appropriate for sending in the message center, like this drug isn't working for me, I have this side effect. But then there's some things that are inappropriate to put in a message center. So I think my advice would be brief in what you're sending your physicians that you need them to know. Be as brief as you can, but try to communicate what you want to say. And then hopefully just if all it takes is a phone call, say it on there. I'm having more abdominal pain. Please call me so that we can see what to do next. That's it. It doesn't have to be this long, elaborate, because most of the time our nurses get those messages and it's like a telephone game. And by the time it gets to us, we've missed the whole message.
That's a really great point. And, and as we get into the more of the pharmaceutical products, that's definitely going to be a longer lead time for feeling symptom relief, and patients definitely want to be aware of that. And also, not to be afraid to talk to your doctor. Like if something's not working, you can absolutely, right? You don't mind if your patient says, Dr. Moshiree, this isn't working for me. I need to try something else. What are my options?
For sure. I hear that all day long, and then at some point I have to commit that, okay, you may not be the right person for any of these drugs. Like maybe I'll go to psychotherapy. Let's do this. If they're more into herbal therapies, I think the herbal remedies can be helpful. We don't have as much knowledge, I think, as MDs as we probably should, because our curriculum, the traditional curriculum for our courses doesn't involve that. But I usually am not a fan of multiple probiotics. Probiotics don't work in IBS-C and getting those kinds of things, but I'm open to hearing what the patient has to say and then what worked, right? I think that's definitely something we have to be more open to too, that we have a responsibility, but the patients also have a responsibility. That's why it's a partnership.
Yeah. And for those patients who are buying every product off the shelves and on Instagram, that just complicates the situation. You don't know what's working, what's not working, what's causing. So as a patient to another patient, right, would you say like, hey, just relax, it's not every patient is different, and you really need to work with your provider to find the best treatment option for you, because every IBS-C patient is not going to be the same.
100%. They are not all the same. And for example, there's other things, right? So sometimes it's not IBS-C, it's like endometriosis. And then we find out, oh my God, like this patient had painful periods and this other stuff. So absolutely, we'll find zebras every now and then that we made a mistake and it's not IBS-C, right? But that's okay. I think if you see the same person over and over again and you establish that rapport, if something's outside of what the diagnostic criteria are, we'll figure it out, right? And we're there to help. So I think being able to communicate with your physician and your provider is really important, but also having that responsibility of knowing why things didn't work. Did you not take it? Because it doesn't mean just because it's in their medicine cabinet. Now that we're doing virtual, I get to see what people have in their. So sometimes they'll open the cabinets and it's like a million supplements. And I'm like, how did you not go into liver failure? Because that's, we see so many patients now that go into, hepatotoxicity of these drugs could be high, even if they're herbs, right? They think herbs are safe. They're not necessarily safe. Those supplements are not regulated. Not in America.
And taken, and you don't know what the contraindications are, if there's any like side effects, things blended and mixed, and
expensive doesn't necessarily mean it's good. Right. It's not necessarily that, because sometimes they'll tell us, oh, but it's in the fridge, and it was an expensive probiotic that I got from this naturopath and this functional medicine doctor, and that doesn't necessarily mean that it's good, because those are still not regulated, right?
Yeah, we did a great podcast a few months ago with Dr. Emran Mayer, who it was like, what does a gastroenterologist tell their patients about probiotics? And he was very candid, and he basically said what you just said. It's like, it's not the be all end all.
There's some definitely good science behind some of the products for sure, but I think not all of them are verified, and there's no body or agency that looks at these probiotics and makes sure that they're okay. That's the problem.
Well, and then they put probiotics in everything, and the message behind it, the gut microbiome being off balance and makes sense, but then it's taken to another extreme. But it's a great episode if you haven't listened to it.
I will. Okay.
Listen, it's great. But I am so thankful for I could just talk to you all afternoon, but I know you have to get back to doing what you do best, and that's helping your patients figure out what's best for them and following up with them. So thank you so much, Dr. Moshiree. I hope we'll have you back again sometime. Again, this is great. Thank you so much.
No, thank you guys. It's a pleasure to be here.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.